It's a case of a 69-year-old man who has aortic stenosis for many, many years. I've been following him for, I would say, probably 5 or 6 years already, and the aortic stenosis had been known for even an extended period of time before that. So he came to a routine follow-up, and I will show you the echo loops in a second. Okay, and I will walk you through. This is the parasternal long axis view. As always, I perform a parasternal long axis view which displays the aorta very nicely, and what you see here is the aorta, the ascending aorta, and I'll measure that in a second. Okay, so 43 millimeters. Remember, he's in his mid-60s, and this is a diameter which is certainly too large for his age and for his body surface area. So one of the information that you can gain from just this measurement alone is that the aortic valve probably is bicuspid, because remember, the bicuspid valve is very often associated with an enlarged aorta. So the aortic valve is probably bicuspid. Now, here is a short axis view of the left ventricle. Take a look at that. I'll be asking you a question later. Of course, there's left ventricular hypertrophy. There's no pericardial effusion. Take a look at its left ventricular function. Here's the apical four-chamber view. The left atrium, I can maybe give you just a measurement of that to give you a bit of a feeling for the sizes of the heart chamber. 56 in this diameter, and the diagonal diameter would be 41. So it's mild to moderately enlarged. I know many of you would perform volume measurements. I would probably also encourage you to do this. Let's do this right away here. Oops, a bit too far down here. I don't go into the pulmonary veins, but I measure somewhere around here. Oops, I'm kind of maybe. Okay, so this would be a volume of something like 77, so it's moderately enlarged. Going back to ventricular function, look at that for a second. I'll just give you a brief estimation of left ventricular size. Okay, we have a dimension of 46, which is normal in size, actually. Okay, I'll just go back to that later. And here is now the Doppler spectrum of aortic stenosis. And my question to you now in the back of your head, how severe do you think aortic stenosis is? We've got a maximum velocity of 6.8 meters and a mean velocity or mean gradient of 122. So maximal gradient of 186 and mean gradient of 122. By the way, all of you can ask questions if you want to. All you have to do is just enter them in your little chat box you have. And I'll also give you a few questions to answer, and I will take a poll later on. But first of all, I want to show you a few more loops. So, but if you have questions with respect to the aortic stenosis or so, just ask them right now. I'll try to answer them while we go along. Okay, so this is the Doppler spectrum of mitral inflow. We have an E wave, which is smaller than the A wave. E velocity is 0.88. And here is the tissue Doppler of the mitral annulus, which is 0.04. So basically, we have an elevated left ventricular filling pressure if you calculate the E to E prime. There is no other major valvular problem. There's no mitral regurgitation, and there's also no aortic regurgitation, maybe a bit of it right here, but certainly not much of it. And finally, I'd like to show you the other apical views. Here is the two-chamber view and the apical four-chamber view. Okay, now that you've seen the images of this patient, and I'm sure most of you see that the severity of aortic stenosis is very, very severe. Remember, usually we talk of severe aortic stenosis if the mean gradient is somewhere around 40 or above 40 or above 50 millimeters mercury, and if the maximum velocity is in the range of 4 to 4.5 meters per second. In this case, remember, the velocity was very, very high. It's 6.8, and the mean gradient is 122 millimeters mercury. So there's no question that this aortic stenosis is severe. But my question to you now will be, why is the patient asymptomatic despite the severity of aortic stenosis. Okay, is it due to the fact that the patient has pseudo-severe aortic stenosis, whatever that is? Is it because left ventricular function is actually poor? Is the patient not really asymptomatic, but he's just telling us something which is not true? Maybe it has to do with right ventricular function? Or is this longitudinal function normal? So here are the results. I think you see them now. Why is the patient asymptomatic? Most of you think that it is because left ventricular function is good. That is why he's still asymptomatic. Some of you think it's because the aortic stenosis is not severe despite the high gradients. Obviously, nobody put the question of right ventricular function or the answer is right ventricular function as an option. And some think that his longitudinal function is normal and that is the problem. Okay, so, well, let me go back to this case again, and I'll show you what my opinion on this patient is. Well, one of the major reasons is that the patient has hyperdynamic left ventricular function, actually. He has such a good left ventricular function that it is able to put up with the severity of aortic stenosis, and because the patient has such a high cardiac output, we have such a high gradient. There are many other things or many other factors aside from the severity of aortic stenosis which somehow influence the gradient. Now, the patient had an aortic valve area of 0.7 if we calculated it, so no question it was severe. But let me go back to the slides and let me show you just some of the reasons why we have a high gradient. First of all, high stroke volume, as mentioned already. In this case, the reason was hyperdynamic left ventricular function. But we can also have high stroke volume if we have a lot of flow back and forth between the aortic valves in the case of aortic regurgitation. There's another reason which is sometimes forgotten. If patients have a dialysis shunt and the shunt is very large, these patients also have a very high flow across the aortic valve, which can increase the gradients in the case of aortic stenosis. Always use the heart rate in your report, put the heart rate in your report, because if patients are very bradycardic, we also have a very high stroke volume for each individual beat, and thus the gradients will be higher. And then there are some other issues which you have to look into. For example, if patients have a very small aorta, then we have the so-called phenomena of the pressure recovery. What does that mean? Well, it means that there is a phenomena which causes the gradients to be higher than they actually should be, or at least the gradients do not correspond with the severity of aortic stenosis. And then finally, if we have a subvalvular stenosis, most likely the gradients across the aortic valve are also let's say higher than they should be. The reason is very simple. If you have a subvalvular stenosis, for example, if you have an outflow tract obstruction, then there's a netto drop in the pressure after the stenosis. And so the gradient before the aortic valve, right before the aortic valve, so between the subvalvular and the valvular stenosis, is low. Therefore, the gradient is high. So if you have something which you see very commonly, namely a subvalvular stenosis and a valvular stenosis, then the valvular stenosis can easily be overestimated in this case. Okay, so, but what happens with the myocardium? Well, if we have pressure overload, the first thing that would happen is we have significant left ventricular hypertrophy, which usually is stronger in the basal septums because that's where the pressure strain is highest. So that's why you will often see a little, septal notch or at least a prominent hypertrophy in the region of the septum. Then what also happens is a change in the geometry of the left ventricle. In other words, the ventricle will get rather small. We have a concentric form of hypertrophy, and to compensate for the now small ventricle to eject enough blood, there has to be a compensation in the sense of more contractility. This happens via a radial compensation. In other words, we have a stronger radial contractile component, and if that that compensatory mechanism can sustain the volume which is needed to be ejected. But then if left ventricular hypertrophy keeps on and gets more and more, then all of a sudden the strain on the ventricle will start to changed left ventricular function or contractility, and that usually happens first in the longitudinal direction, and especially at the base. So up to here, everything that is green is a normal compensatory mechanism, but once we come down here, we really start to see a reduction in left ventricular function. So basically, hyperdynamic radial function does not mean that left ventricular function in the longitudinal direction is normal. As a matter of fact, very often you would then even see a compensatory increase in radial function because the longitudinal function is getting worse. So let's go back to this case and let's look at it more closely. Here we have hyperdynamic radial function. You see that the endocardium is almost touching each other. And the same is also visible here in a short axis view. You can see that we have a very hyperdynamic function. But what about longitudinal function? Okay, now this is the mitral plane, and if we use an M mode right through the mitral annulus, we can see that this annulus does not move very much. It's only 11 millimeters, which means we already have some form of deterioration of longitudinal function. And if you want to go into more detail to look at the left ventricle and the different contractile components, you can use speckle tracking, and this is such an image. And what do you see here? Well, you see that truly longitudinal function is starting to deteriorate here in the basal septum and the basal myocardial segments, and it's still okay here in the apical segments. So what usually happens in aortic stenosis, you will have a gradual decrease from basal to apex with respect to longitudinal function. So how do we put all this together? Well, basically what happens is that usually we have left ventricular function which is still preserved here in the apex, but deteriorates in the basal segments. The question now is, what do we do with this patient? Well, he's not really completely asymptomatic, because when I talked to the patient, he said, well, he's happy with what he can do, but he's not trying to do more. So what I did was I put him on a bicycle, and obviously he did have a reduced exercise capacity. And because of all these beginning changes, and because the gradient was so high, I convinced him to get an aortic valve replacement. And he will now get a CAT study done next week, and then he'll go then to aortic valve replacement. So now, even though this patient does not have such a clear-cut indication for aortic valve replacement, you know, he only has maybe trivial symptoms or so, all these other findings, namely this deterioration of longitudinal function and the very high gradient, I think is a good reason to put him to aortic valve replacement. Also, considering that it does show that the patient probably will deteriorate also with regional, radial function pretty soon, since aortic stenosis is already so severe.